I'm going to talk about the modern management of spinal injury and just their disclosures and Duncan did a good job with his talk and started the quote. I figured I'd copy him. So, spinal cord injury, there's a lot of studies, none of which are very high quality. Dr. Day is beats this into us from a young age that understanding the relevant anatomy and normal disease processes or normal anatomy and pathophysiology kind of forms the basis for how you treat it. And so we'll go over background, pathophysiology, and then kind of what we can do to help. So for spinal cord injury, 90% of this is mechanical destruction of tissue. That happens when the injury happens. It's not modifiable by us by the time it gets to the hospital. It's more policy issues and education, the way to modify it. And so what we're really left with is secondary injury. And the main tenets of that are continued compression and cell destruction, cytotoxicity, cell death, and ischemia from loss of autoregulation, and then inflammation. And those are just the broad strokes of really in-depth categories of research that people spend a lot of time on. And this is really what we're focused on. And it's the thing we can modify. And animal studies estimate that about 10% of spinal cord injury is caused by secondary injury. And so I guess that begs the question is, does 10% really matter? And it matters to me. And I hope that by the end of the talk, I can convince you that it should matter to everybody. And from a epidemiologic perspective, it's a devastating disease. 17,000 people in North America will have a spinal cord injury, most of which are cervical spine. Kind of put that in perspective, there's about 12,000 new GBM diagnoses a year. What's different with this is that people with spinal cord injury live a very long time, and a 25-year-old male who has a high cervical injury will have about $3 million of direct medical costs and can have up to $8 million of indirect costs. And that data is 10 years old. So, my background, why I'm interested in, I grew up in Atlanta, about a couple hundred yards from James Shepard's house, who founded the Shepherd Center, which is functionally tier of Atlanta. He had a spinal cord injury when he graduated college surfing. And so it was, something I'd seen the long-term effects of from a young age. Unfortunately, when I started my career as a baseball player, we had 2 players in a year that were paralyzed from different reasons. One on the field, one was coming home from the library. And, seeing the impact it had on them is pretty profound. And it's kind of then I realized that there's not all that much that the surgeons do in spinal cord injury other than operate and manage the complications up front. And this is an illustration that I kind of borrowed from John Hurlburt, who is at Arizona, and he put this in perspective, and I thought it was really a good way to think about this of why that 10% matters. And if you think about the spinal cord as having 100% of function, completely intact axons, we know there's a redundancy. You can have pretty significant compression, significant myelopathy with kind of minimal symptoms. And as that progresses, you start to lose function on stuff at first, but then if it gets bad enough, you'll start to have weakness. And similarly, if you transect 90% of the spinal cord, there's kind of a critical mass that you need of neurons to function and move. And neurosurgeons often get discouraged, where an ASIA A patient, if you're saving 10% of their spinal cord, you may not see a significant benefit, but 10% here could be the difference between walking and being in a wheelchair. So how do we do it? How do you prevent secondary injury? And there's not a ton of tools we have to do so. And the main ones that I'll focus on today are spinal cord decompression, spinal cord perfusion, and management of hemodynamics in the acute setting. Arterial oxygenation is critically important. Getting these people on oxygen early, maintaining their arterial oxygen supply so you're delivering oxygenated blood to the spinal cord is important. And then I could do a whole talk on complication avoidance in spinal cord injury. 40% of the cause of death in spinal cord injury patients is pneumonia, and it's exceedingly common, and it is under-recognized often in the acute setting because it kind of lags behind, and they're pretty sick by the time we pick up on this. But another piece of advice I got, from different people in training is when you want to study a disease, find the people that know what they're talking about, follow what they do, and try to expand on that. And Failings is, obviously well known in this field, and he seems to get it. And he's come up with this concept recently of time is spine. It's akin to the stroke literature of time is brain, where getting TPA in quick is the most important thing. And the background of this is pretty solid. And there's a study from Kentucky, 2000 or 1999, where they did spinal cord injury in rats, and they left a spacer in there that took up a varying diameter of the cord or the canal length, between 20 and 50%. And then they also left it in there for a variable amount of time. And on the left, this is different size spacers. So with no spacer, the rats recover to a pretty good functional level. 20%, you see a little bit less. And then 50% and 35%, you see pretty significant dysfunction. And this is at a consistent time where they removed it. On the right is the temporal relationship of this, where they used the same size spacer and they took it out at 0 hours, 2 hours, 6 hours, a day, 3 hours. That 0 and 2 hour graph is pretty close, and those animals did about the same, with a little bit of difference. And I think the really highlighted this paper for me was the histology, and you can see pretty clearly this is when they took the spacer out at 0 hours. This is when they took the spacer out at 3 days. And if it's my spinal cord, get the compression out as soon as you can and as close to injury as possible. The human data is not as good because of some of the limitations of studying spinal cord injury. It's hard to randomize trials to, early versus late, and it's really hard to predict outcomes in spinal cord injury, which is changing, but still limited. And this is study Failings did, where he looked at all the trials, all the major trials, the stasis trial, all the steroid trials, where they had prospectively collected data in about 1,400 patients. And the graph on the left is motor improvement and by time of surgical decompression. And it plateaus pretty quickly at 24 hours. And the most significant improvement is before that. Something I'll point out from that study is just the demographics of this cohort of patients. And this is changing. And it's going to be more and more a part of every neurosurgeon's practice as time comes on. And you see fall is 28% of the patients, and motor vehicle collisions and major high velocity injuries are a higher percentage. And the age is young, 38, 39, and this is shifting as the population ages. There's more degenerative myelopathy. More and more of these spinal cord injuries are going to be falls with pre-existing stenosis. And even in the last 10 years, studies are coming out more. This 45% of motor vehicle collisions and 28% of falls, that number's flipping. And as more and more people get older, people coming in with less severe incomplete spinal cord injuries with pre-existing degeneration is going to be more common. This is a big data approach they use to kind of stratify people and predict outcomes. And one of the biggest problems with trials of spinal cord injury is outcomes are extremely variable, and predicting who's going to do well, who's going to do bad is exceedingly difficult. And I'm sure our visiting professor could tell us a lot more about the big data and bioinformatics that goes into this. But they did a group-based trajectory analysis, and basically they plotted all of these incomplete cervical spinal cord injuries over time and clustered them into kind of who gets better and in what time course. And it turns out that it actually is pretty simple, and things that predict who's going to get better and what the recovery profile is going to look like, you only really need three things. And that's how bad off you are when you come in, where the injury is, and then age. And with those three things, you can, form these type of trajectory analysis and really cluster patients into this is where I expect this person to go. This is where this person should go, and reduce the number of patients needed for trials. But the reason I bring this up is we're focusing on early decompression being critically important. And when they looked at what other factors in these groups that clustered based on those data set or based on those variables, the only factor that was different between any of these groups is early surgical decompression. And people with good recovery and excellent outcomes are more likely to have early surgical decompression. And when all this started, the big question was, is it safe? And there's been a significant number of trials now, and this is a forest plot, and this is morbidity and mortality. This is actually mortality. Morbidity looks almost the same, but mortality goes down, length of stay goes down, morbidity goes down with early surgery. And I was kind of goes against what the big concern was, which is doing surgery early is gonna be dangerous. They're gonna be in the hospital longer, or they're gonna have more complications. And turns out it's actually the opposite. Now, despite this, the guidelines, which are changing and are supposed to be updated in the next year, say we suggest that early surgery be offered as an option for adult acute spinal cord injury. And why may that be the case? Now, the group out of Maryland is one of the other groups that does high quality research in this, and their main focus and their thing that they really think is valuable in decompression is the degree of decompression and making sure you have CSF on both sides of the cord. And they think that they looked at 72 patients that was retrospective, but 72 patients where they did post-op MRIs on all their patients to confirm adequate decompression, and determined that early surgery was not actually beneficial. It doesn't influence the outcome. It's just whether or not you get fully decompressed. Now, I bring this up. I can't remember who showed this to me, but it's important to remember in spinal cord injury this is a kind of satire article from British Medical Journal, but this study proves a point where they looked at 92 patients, randomized controlled trial, to jumping out of an airplane with a parachute or an empty backpack. And they found that it didn't reduce death, morbidity, mortality, but compared to the individuals screened and not enrolled, people that were enrolled were more likely to jump from 0.6 meters from an airplane on the ground versus 10,000 meters. And the point of this is, when there's beliefs regarding whether something works or not, trials and studies may selectively enroll people with a lower likelihood of benefit, and kind of diminish what this means broadly. And if you go back to that study before, that was 72 patients out of 3,000 consecutive patients where somebody determined that they have adequate decompression. And that kind of highlights back to the beginning here, is understanding the relevant anatomy and pathophysiology forms the basis for what we're doing. And it has to make sense. Just because the study doesn't prove it, what you're doing needs to make sense. So how to minimize time to decompression. What we do is, I'll go over the protocol next, but the idea of, code spine or code similar to a code stroke is kind of coming into favor in the literature. And it's not possible at every center. It's not possible, throughout the country at smaller hospitals, but at major centers, and we're lucky with Life Flight that patients get here very, very quickly. But, we're consulted immediately, and all the residents know this, are resuscitated, posted, taken MRI, taken straight to the OR. And, how do we do? This is like 10 patient old data or 8 patient old data, but the last 25 patients we've had, the age is 49, half are falls, which is consistent with what I was alluding to earlier, that more and more people are going to be older and coming in with falls and
pre-existing degeneration and myelopathy. And we are pretty from the time they hit the door to the time we're cutting skin is about 5 hours. If you take out 2 people where the ER didn't call us for a while, it's about 4.5 hours. This is where we really make a difference, I think. And the time from when the injury happens to when they get to us is about 2 hours, and that for 2.5 hours, that's really fast. Even shock trauma in Maryland's not that fast. And that's just a credit to our system and how it's set up, and limits how applicable this is nationwide, but it brings the mean time to injury to skin incision to about 7.5 hours. 22 or 88% received ultra early surgery. All of them received early surgery. And there's no intra-op complications. Nobody was worse after discharge. We have pretty good, inpatient conversion rates of, acute changes to improving. And how does it stack up nationwide? And so this is a study that they did looking at all the National Spinal Cord Injury Trial Centers and how many of them got surgery within the first 24 hours after injury. There's a typo in that graph, but the best that has happened in the last few years is about 80%, and it's about 70% last year. And 40% of them are getting surgery within 12 hours, 30% within 12 hours. And the question is it a lack of understanding? Is it a systems issue? What's the kind of cause of it? And they did a survey of all the spine surgeons. 93% of them thought early surgery was the right thing to do, and surgery as soon as possible was the correct outcome. So it doesn't seem to be a knowledge thing. And so what's the variability? Severity of neurologic injury, day of the week, and what center is treating it. And that kind of argues to the point of it's not easy to get out of bed in the middle of the night and do huge front back surgery, and it's not fun. And that's part of the job, though. If you looked at the last 25 patients we had, the incision times on the right are the ones during business hours, and the rest of them are the times we cut skin on the other patients. So minimizing time decompression is important. What else do we need to do? We actually need to perform a decompression, and then the question is validate it. The group at Shock Trauma, I looked at that. We showed that study earlier, and these are kind of the 3 studies that led up to that. And they looked at the chance of conversion for grades from B to, or improving one age grade, and the probability of conversion was significantly higher with complete decompression across all the segments that had T2 signal change on a sagittal preoperatively. 60% and 20%. It's pretty stark. And how often do we get decompression? So they looked at 184 of their cervical patients, and they cited a paper that was guidelines for acute cervical trauma. It was published in 2007. That basically is a flow chart of if you have a burst fracture at C5 with, without jump facets, the treatment is corpectomy alone, without posterior fixate or without laminectomy, unless there's something posteriorly. And it actually argues for anterior surgery alone in a significant number of acute cervical traumas. And they said that all their surgeries were in congruence with that, and defined decompression as circumferential subarachnoid space. And only 120 were decompressed, 46% in ACDFs, 60% in corpectomies. And if you add laminectomy to the surgery, that number goes up to 72, 73%. And laminectomy was the only surgical type or surgical addition to whatever procedure you're doing that correlated with decompression. So how do we do? We don't really look. We have in the last 25, 3 didn't get laminectomies, 9 didn't get, in the posterior only group. 2 didn't get laminectomies in the front back group. And the reason for this can be variable. Sometimes patient may be in Asia A with a near complete transection and an obvious CSF leak, and you don't want to open up the fecal, you don't want to open that up and release CSF and kind of open Pandora's box. And the answer to did we adequately decompress everybody? We don't really know. The group in Maryland does post-op MRIs on everybody. And there's probably some adjuvant alternatives that can help us here, because that's a pretty significant use of resources for every spinal cord injury patient to get pre and post-op MRIs. And they looked at intra-op ultrasound and the reliability to determine whether or not patients were adequately decompressed. And in all cases they used it, they felt that it was decompressed in ultrasound, but that correlated to about 84% in MRI. 6 were bony, residual bone decompressions that needed to be done. And then in rare cases, there were 2 cases that had circumferential swelling where the cord filled the whole thecal sac despite decompression. And that's led to people looking at duroplasty and the role for that in spinal cord injury. There's a randomized trial going on right now with duroplasty and whether or not that's beneficial to alleviate space. And the results on that are kind of still to be determined. Now, the second thing we really have control over and can do is control the perfusion to the spinal cord. And you go back to the pathophysiology, and this is spinal cord perfusion pressure equals MAP minus intrathecal pressure, intraspinal pressure, whatever you want to call it. And it's a homologue to traumatic brain injury literature. And this is the autoregulation curve on the left. It's normal. And we know in traumatic brain injury and vasospasm and subarachnoid hemorrhage, this autoregulation curve is lost. And it's been known for a long time, the studies from 1979, that in spinal cord injury, that curve that should be flat through this range here tilts straight upwards. And when your blood pressure goes down, your perfusion goes down. When your blood pressure goes up, your perfusion goes up, and you lose that ability to functionally regulate it. And that puts the tissue kind of in the penumbra of the injury, where you have the injury where the cells are dead, it's totally dead, the tissue's not coming back. But then there's an area with altered perfusion and autoregulation just around the injury site where this is going on, and there's opportunity to save tissue. And so what does the clinical data say for this? And our guidelines, which are changing, are supposed to be coming out soon, that you can consider doing MAP of 85 or for 5 to 7 days and avoidance of hypotension. But they give a caveat of weigh the risks against limitations of data, risk of vasopressors, prolonged immobilization, consumption of critical care resources. And it's based on the study from Dr. Hadley at UAB, and there's no control group. It's basically anecdotal, and that's kind of what all this has been based on from the human studies for a long time. And one of the things that I'll point out is in their original paper, they say, we don't know how to measure spinal cord perfusion in the clinical setting at this time, so we just arbitrarily selected a MAP target. And 85 worked for brain injuries with an ICP of assumed to be 15. Why wouldn't it work for spinal cord injuries? Which makes sense. It is similar, and the idea of measuring spinal cord perfusion wasn't really possible then, and is just sort of now coming into favor of something we should be doing. And so I think this is probably the most striking study that I found in terms of what actually hypotension does in spinal cord injury patients. And we looked at all the patients that improved and the percentage of MAPs at any point in their hospitalization with high frequency monitoring, where they're measuring every minute, that fall below 85. And the people that improve, that number's about 20% or less. The people that don't improve, that number can get as high as 30-40%, particularly in the incomplete spinal cord injury patients. And if we go back to spinal cord perfusion pressure is MAP minus intrathecal pressure. And it's logical that, we don't really care what the MAP is. We care what the blood flow that the spinal cord's seeing. And so how do we augment that? You can augment that with CSF drainage. And this is the pilot study where they looked at, does draining lower intrathecal pressure? And there's kind of mixed results on this. The consensus is yes. To what degree, not really sure. And over time, it lowers the intrathecal pressure and, increases the amount of perfusion the spinal cord seeing. This is another study looking at spinal cord perfusion pressure. And one of the things I'll highlight here is we don't do a very good job of this, and it's not easy. It's something you really have to stay on top of. But if you look at the ASIA patients in their study, and this is pretty consistent across a lot of people's data sets, they're seeing less than 60 millimeters of mercury spinal cord perfusion pressure 27% of the time, MAP of less than 80, 35% of the time, and really low values, perfusion pressure less than 50, 5% of the time. And that's pretty consistent across multiple groups. And when they looked at how many times people were exposed to spinal cord perfusion pressure less than 50 or critically low perfusion pressure, those people are significantly less likely to improve, despite the number of times, and that's irrespective of the number of times their MAPs drop. And what it's kind of highlighting here is what seems to matter is what the spinal cord is seeing, not what the arterial blood pressure is. Measuring this with the lumbar drain is not the best. It's not perfectly accurate, but it's pretty close. And so how have we done? This is older data, but the rest of it looks about the same. But we're pretty good at meeting our. I'm missing a slide here, but we're pretty good at meeting our spinal cord perfusion pressure. We do that 75% of the time. MAPs are 65% of the time, which is pretty consistent with what they're reporting in terms of you're more likely to be at spinal cord perfusion pressure goal than you are at a mean arterial pressure goal, and it's easier to meet. Implementing this is not straightforward. It requires a lot of education. It is a big drain on system resources because it requires them to be in the ICU and requires a lot of education of the nurses to figure out how to do this and monitor it and act on it. So I'll highlight a couple things in terms of what neuroprotective strategies are out there and what's kind of next. We know that early surgery works. Perfusion-based hemodynamic management is coming, and there's more and more data coming out about this, and I expect that to kind of take over in terms of how people are managing this, despite the fact that the next guidelines that come out are going to actually be less strict about hemodynamic management. What I think it's going to say is that we recommend strict avoidance of hypotension, and that's about it. There's neuroprotective drugs. The Relozu trial, I can't say that word still, was negative, but there's a few more that are kind of on the horizon. And where I really think that things are going to get better is looking at large data sets in terms of personalizing rehab, personalizing your therapy after spinal cord injury, when and how much therapy you need, what's the best way to do it, and how to kind of stratify people into who's going to improve in what time and how to maximize their recovery. And as more and more data sets are generated, I think that modeling and bioinformatics is really going to help us both prevent complications and kind of figure out what the best strategy is for each patient. And then duroplasty, the trial on that is ongoing. Whether or not that's beneficial, I imagine there's going to be a lot of complications from this, just from everybody's been in a case where there's a big CSF leak and a spinal cord injury, and that's not a fun place to be, with a lot of swelling and tissue damage and cord coming out at you. But maybe that'll be beneficial. But the regenerative side of things are exciting, and the tissue engineering studies are interesting. There's, cellular based. I'm doing work in exosomes, so I'm partial to that, but stem cells, different acellular therapeutics are coming. But I think the most exciting part of, where we're going in spinal cord injury is kind of looking at what they're able to do with brain machine interface and chronic spinal cord injury. And this isn't a new idea. People have been trying neural stimulation, epidural paddle stimulation since the early 2000s. But this is kind of the big one that came out in 2018 in New England Journal of Medicine. And what they did is, excuse me, they put in an epidural spinal cord stimulator, and they did EMGs, and they did basically mapping of where to activate a anode and a cathode in the spinal cord stimulator to elicit an EMG response in muscles. And they put them through a series of exercises where they were telling them to do exactly certain things and then stimulating the exact muscles that were required for that. And what they found is they can improve a significant number of things. They can ambulate, they can stand, and that it's significantly better with the spinal cord stimulator and with it on. And that is getting expanded upon to study that came out last year as sort of a not closed loop, but something that's portable and something that doesn't require them to be hooked up in the hospital. And what they have done here is they've put grids over the somatosensory cortex in the predicted areas of activation for movement and sensory areas. And they ask the patients to do a whole bunch of things, flex your right knee, flex this, flex that, and they map out the brain. And then they put these in and they confirm it. And they use a machine learning to say, when they're trying to do this, this is what needs to be activated. These are the muscles they're trying to activate. This is coupled with an epidural paddle stimulator over the conus, and those two systems talk to where if they're trying to activate this, then the sensor fires and does that. And the results from this are pretty striking. This is the EMG pre and post a year of having this. And what's interesting is that this effect continues after you turn it off. So you do this you have this on for a year, and their strength improves, their functional connectivity improves, the actual neural circuits are improved without this being on. And maybe long term, that's enough to get somebody walking, or maybe long term they need some sort of chronic stimulation that turns into a wearable device that they go with forever and needs battery changes and all that. But just the concept of this is critical. And one of the things I'll highlight here is, if you look here, this is firing the hamstring muscles. This is before and after implantation of this device. And if you don't have, you see this is completely flat. There's no firing, there's no electrical activity, it's not working. And then after a year of this, you start to see firing. And it comes back to the point of, does 10% matter? And if you put the line of walking here, if you save this 10% of 10 to 20, and now the new epidural paddle stimulators or whatever the next regenerative restorative therapeutic is, all of a sudden gives you 50%, that 10% could mean a lot. That 10% could be still in a wheelchair, or that 10% could be walking. And so, does it matter? I think so. And so just to kind of wrap up, early and adequate decompression improves outcomes. It's important. It's not fun. It's not fun waking in the middle of the night, coming in and doing it, but it's the right thing to do. And looking at the system, healthcare systems and how to improve that, and whether people need to be going to a center that does a lot of spinal cord injury, like a stroke center, may be something that needs to happen. Maintaining perfusion to the at-risk spinal cord is critical. It's figuring out how best to monitor that and how best to do that, and what the right target is you know, something that's still ongoing. And I think over time, this probably will be individualized, where a patient that is high cervical Asia A that is really having trouble with their blood pressure, they're in shock, you can't keep it up. It's probably not the right thing to do to put them on a third pressor to get their, blood pressure to 85. And I think over time, with enough data and enough granular data, figuring out who the people are that won't benefit from that will become evident, and who the right people are to really be aggressive with will be. And then, there's hope on the horizon for regenerative, restorative therapies that'll really improve functional status. But most of these therapies rely on restoring what's there. So you have to save as much of the neural system as you can. And, restoring and modulating it only works if there's, a significant amount of it left. So do what you can to save it. And yeah, any questions?
Well, that's great. Actually, Mo, you happen to be here after this talk. I was not at the Spine Summit, but I heard through the grapevine that you were debating Mike Failings on this exact topic, I think. I assume you probably disagree with some of the conclusions, but
yeah. So
maybe
specific.
those of us who were not there,
Yeah.
just summarize for us the debate,
Right,
and
right.
maybe address.
Yeah, no, it's a pleasure to be here with all of you. I'm Mo Biden. I'm a neurosurgeon in the clinic. And you did a great job, Dr. Withrow. Did I pronounce your last name correctly?
Yes.
You did a beautiful job and a very nice summary of the data. This is what I was planning to talk about. This is a great timely topic. I would say perfusion matters. You said, I fully agree. Decompression matters. Fully agree. 24 hours is the magic number. I challenge that. And we had a lively discussion at the Spine Summit on it. Everybody voted afterwards. I won the vote, but that doesn't mean necessarily. But I'll point out a few things to you, and I think it's important to think through this. Can you go back to your slide? You had one slide that said, "Is it safe?" Can you go back to "Is it safe?" Yeah, right there. Okay, there are 1, 2, 3, 4, 5 studies on the left side of the graph. What's the one study that's on the right? It's Michael's study. Okay, you see this all the time, and he's shifted the whole literature just with his individual studies. And everybody, it's not reproducible. Everybody else is on one side. And where the studies come out of Toronto, they're always on the other side. And we see this consistently. Now, go back a few more slides. Go back one, wait, hold on, right there. Okay, you're correct in that early surgical decompression was statistically significant. What else is statistically significant?
Grade.
And age.
Yeah.
Right? And so, and for the age to be different tells you that there's outliers. And this is the problem. A collection of bad data doesn't create good data, right? In fact, it's worse to have bad data than to have no data, because it leads you to bad outcomes. Or to bad results and bad conclusions. So I'll give you an example. Where I am on this, I think is where most of our specialty is. and you'll see there's gonna be responses to the AO guidelines. First, the AO guidelines that are coming out are controversial within AO. There are people on the AO board who disagree with them. Second, there's gonna be responses from both the trauma section and the spine section that will be coming out in the literature specific to those guidelines. And it's good to have a healthy debate around it. I think where I am, where most people are, is take them as soon as it's safe, right? Take them as soon as it's safe, as soon as you can, as soon as feasible, take them to the OR. And I think that's where most people in our specialty are. The question is the magical 24 hours. Well, you alluded to this. 24 hours is not always 24 hours because in most of the studies, it's from time to ER. But in your ER, people show up right away because you've got 4 helipads and you've got, it's your kind of, the mecca of trauma along with shock trauma. So you've got a different setup than what every other hospital in the country has in terms of when patients show up. So the majority of these studies, you don't know when the actual injury occurred. You don't know the adequacy of the decompression or the perfusion. And yet you're drawing conclusions on one variable. And so in the majority of the country, the patient that you take within 24 hours, there's a reason you are. They're healthier, they're younger, they're safe to go to surgery. The patient where you're waiting 3 or 4 days, they're in shock. I mean, there's some reason why you're waiting. And then all of a sudden the study comes out, oh, going early safer, it's better. Well, you made a decision. That was not a random collection of when things occurred. You chose to take them earlier because they would do better. So all of that, and then the pooled analysis, the PICO questions. Okay, this is about guidelines. So I used to be the chair of guidelines for the CMS, and guidelines are really important, actually, how you do them. You have to, there's something called PICO questions, and you have to predefine your PICO questions. Once you define them, they cannot change. And in the AO guidelines, which there's going to be a methodology article, Patty Raskin, head of the JTRC, head of the guidelines for our specialty, where she challenges whether these are even guidelines. Because these PICO questions were defined at the beginning, but then had a meandering, flavor to them. And that's not how it works. And then the questions were kind of leading questions also. And so there's, and I would say generally, I would fall into the Araby school, which is the shock trauma school, which is, look, there's a lot of factors. Time might be one of them. Why'd you land at 24 hours? Why isn't it 22? Why isn't it 22 and a half? Why isn't it 25? How do we get exactly to that number? And this is where all the time articles go. Cardiac guino within 48 hours. That's based on the ON article. ON was at Johns Hopkins. When I was at Hopkins with Zia, with my brother, who's a neurosurgeon at Hopkins, we looked at all the cardiac guino cases. We looked categorically, ordinally, and continuously. So there's 3 ways to look at time. Ordinal means first in, second in, third in, fourth in. Continuous means you're just measuring across. You can have decimals, you're just measuring across, first to last. And then categorical, which is the worst way to measure time, means you impose the category. So 6 hours, 12 hours, 24 hours, 48 hours. That's the worst way to look at time, 72 hours. Because if you create enough of those categories, you're going to have categories of patients. Now you put 5 categories of time. Definition of the p-value, one of them will be significant. That's just by the definition of the p-value. So, and so that's what ON did. And oh, lo and behold, 48 hours was the magic hour. Well, how does that make any sense? What's so physiological about 48 hours? So, but what we found when we looked at the actual Hopkins data, we didn't find that to be the case. If you look categorically, you find 48 hours. But then if you take the individuals, if that were to be true, then the first patient in should do way better than the last patient. That wasn't the case. The first patient should do better than the second patient. That wasn't the case. The continuously, when you look at it, you should see significantly better improvement and it should go down. That wasn't the case. So when you then challenge the time notion, the whole case collapses. So, I would say you did a great job. These guidelines are out there. Some of the people, one of the people working with us is an author on the guidelines paper. He didn't even see the paper before it got submitted. So there's a lot of issues methodologically. And then you have, and why do we challenge this? Why not just leave it alone? Because then, as you guys know, you're going to have, my wife's a lawyer, my sisters are lawyers, great respect for lawyers, but you have lawyers who are going to show up and who are going to say, oh, doctor, this patient went in 25 hours, didn't they? And all of a sudden, that's gonna be the basis of the lawsuit, and it's gonna create all these issues. And so, all of that creates problems. And so we shouldn't put something out there in a guideline unless we're very confident of it. And in the pooled meta-analysis in which one trial pushed everything over, done by the author, that, is not the right way to do it. So those would be my arguments on time. I appreciate that that's one part of what you discussed. I think everything else that you discussed is spot on. Other things on the stem cells, I have a paper in Nature Communications that'll come out on April 1st, where we did stem cell trial for spinal cord injury and had, it was a phase 1 trial. So we had good safety, but as a secondary endpoint, we looked at outcomes, and we had good outcomes for those patients. 3 of them responded in a significant way. 3 of them didn't improve, but didn't get worse. As I look at it, to me, it's an accumulation of things. And so it's going to be stimulation plus brain machine interface plus stem cell regenerative therapy, whether that's the cells themselves or exosomes as you're working on. So I think all of that. And as I look at, in terms of initial impact, I think it's an accumulation of things. And so those would be my comments. I think you gave an excellent talk. But just wanted to give a little flavor to some of the discussions.
The timing is interesting,
guidelines.
yeah. That's right.
Yeah, so, yeah.
I'm going to make two different comments along two different lines. First of all, between your talk and Duncan's talk last week, I thought we saw spectacular presentations of an organized topic that's very complex. You delivered it in a very simplistic thing that even a vascular or skeletal surgeon could understand. Follow the sequence, and I think that's such a credit to you and the work that you've done and to Duncan's work, but also to the process of getting you down to what you like and what you can get enthusiastic about in the research time that you had. For those of you who don't know, it was a trial to get Joe to find out what he was actually going to do. We had numerous sessions to figure out where his Georgia brain was going to orient and where it was going to end up. And of course, we had the same phenomenon with Duncan, who was going to be an endovascular guy, and then whatever they migrated, unfortunately, they migrated south into spine instead of north into cranial skull base. But for the younger residents to see if you can find something you like or you're really interested in, and you can then you like it surgically and you like it clinically, and then you can do this kind of stuff, then your opportunities for making it something spectacular. That's our goal. And the credit to Spiros and Nitin about how they've been counseled to arrive at this endpoint. It's not easy, but that's the desire of our program, is that every single person to reach this goal individually when you come out of this program. That's our goal. The second is, being the oldest person here by somewhat shades, I've seen the pattern of nihilism of certain diseases that we've dealt with over our lifetime. Obviously, subarachnoid hemorrhage, where the brain was swollen and angry, that we didn't know what hydrocephalus was, and we didn't know what perfusion pressure was, and every grade 3 child that had severe spasm or whatever was maimed for life, and now the process is different. The acute stroke and the time it took and the number of studies it took to find out that thrombolysis actually worked. There were so many obstructions to doing that, so many negative studies until we finally got it right. And of course, I've operated on a number of these and done duroplasties when I was younger or whatever, always in the back of my mind saying, why are we waiting? Well, we waited because the cord was swollen, and we would put every cervical spine injury in a room like we did with aneurysm rupture and wait for about 10 to 14 days. And then if they still hadn't died from pneumonia or whatever, then we decompress it or whatever. Somewhere in between. This is so exciting to see the progress that we've made here, and so exciting to see you interested in it the way you've delivered it. It's just a testimony to our youth and our future. Well done.
That Nature paper you quoted at the end, that excluded like obvious transections, right? Those
You have
papers.
to have, all of those studies, you have to have their ASIA B or better. The first paper, I think they were all ASIA Cs, but
you have to have some feeling.
Yeah.
I think you have to have actually intact sensation in your lower extremities, in every group.